Hello, I'm Dr. David Wohl, and on behalf of CME Outfitters, I'd like to welcome you to today's educational activity titled COVID-19, Setting the Stage for Improved Outcomes with Targeted Therapies. Today's webcast is supported by an educational grant from Pfizer and Merck Sharp Dome. Today's activity is brought to you by CME Outfitters, an award-winning jointly accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters, one word. We'll be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on the slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us feedback on the program and the platform as well. Again, I'm David Wohl. I'm at the University of North Carolina, where I'm a professor of medicine in the Division of Infectious Diseases. You could read it all there, but I help lead our global prevention and treatment research site and work on viral hemorrhagic fevers. Okay. Now I'll introduce our fabulous faculty. Joining me today is Aima Ahanke. She's an assistant professor of medicine at Vanderbilt University Medical Center, Division of Infectious Diseases in Nashville, Tennessee. Welcome, Aima.
Thank you so much. Very good to be here, David.
And also Dr. Onyema Agbu-Agu, which I always mess up, so I just call him Onyema, and we'll do so from here on in. He's an associate professor of medicine. He's also director of the clinical trials program for the Yale AIDS program at Yale School of Medicine in New Haven. Onyema, welcome.
Thank you, and hello everyone, and we're really pleased that you're making out time of your day to join us.
And lastly, we have Dr. Pratish Patel. He's program director for the Department of Pharmaceutical Services, also at Vanderbilt University in Nashville, Tennessee. Welcome as well.
Good evening, thank you.
Great. So the first learning objective for today's activity is characterize the short-term and long-term disease burden of COVID-19. So Aima, can you start us off with a current CDC update of the consequences of the pandemic?
Sure, I'm happy to do that, David. As we are all very well familiar with at this point, COVID-19, this pandemic is certainly the defining pandemic of our generation. So much so that we've all gotten used to looking at slides just like this one from the CDC. This shows that as of today, we have had more than 50 million COVID cases in the United States. The 7-day case rate is nearly 250 per 100,000, and that's actually been steadily climbing since the end of October. And we have lost nearly 800,000 lives from COVID-19. The map of the United States on the right emphasizes another important point that we've all experienced. There is substantial regional variation in our local epidemics within the US. And currently you can see from the darkest blue states on the map that have currently the highest burden of disease in the Northeast and New Mexico and Kansas, for example. So let's talk a little bit about variants. This is something that, of course, is on everyone's mind these days. What are variants of concern? And before we do that, we'll back up just a moment and just remind ourselves that viruses are constantly mutating when they replicate. And so when mutations develop that provide some selective advantage to the virus, then the virus of mutations can predominate in the community. We've seen this happen now a few times with the SARS-CoV. And variants are really defined by that genetic code of the virus with its new mutation or set of mutations. So As a result of this, our public health agencies are using surveillance techniques to monitor for variants of concern. And these are defined by whether or not a new variant has increase in transmissibility, in disease severity, or decreased effectiveness against our prevention and treatment options that are available, in addition to difficulty in detection. So if it is more difficult for us to detect with our current tools. The current circulating variants of concern that we've been talking a lot about in the United States and worldwide are the Delta variant, and Omicron variant. So as described on this slide, the Delta variant was first identified in India in late 2020. As we know, the Delta variant spread more easily, more readily than prior variants. It's not clear that it actually caused more severe disease, but it certainly spread rampantly throughout the United States and really strained our healthcare system as a result. This is the first time we started to see breakthrough infections in fully vaccinated people under the Delta wave. And at this point, it's clear that nearly all variants of Delta that are circulating are fortunately in the United States responsive to FDA authorized monoclonal antibodies, and we'll be talking more about those today. Omicron, of course, is the newest variant of concern, and that was first identified in South Africa in late November. This, of course, we're hearing more and more may spread even more due to the constellation of mutations that are present in the spike protein. We're still at this stage gathering information to determine the level of disease severity and mortality caused by the Omicron variant, but there's still a limited number of cases. And as we do more research, we'll be able to characterize that risk better. It is clear, though, however, that we are seeing breakthrough infections in fully vaccinated people, and we've seen that in the cases that have been described. We'll have to stay vigilant to determine whether or not the monoclonal antibodies that we have are effective against Omicron and other.
Terrific, thank you. That's very helpful to go over that, up-to-date information. So, Anyema, I'm going to turn to you because I think one other thing that we should talk about is we think of COVID-19 as being oftentimes an infectious pneumonia, but there is a role for the inflammatory cascade that also has to be thought about in the pathogenesis of COVID-19. Can you review some of the maybe quote unquote off-target effects of COVID-19 beyond the pneumonia?
Yeah, thank you, David. Very pertinent, I think, to remind the audience that, COVID-19 is definitely bigger than a pulmonary disease. And, we see this manifesting in the patients we care for who have had involvement of other multi-organ systems, and that contribute to morbidity and mortality in many cases for COVID-19. And I think, very early on, we saw just the model of what the COVID-19 infection looks like, which is mostly an initial viral replication phase. And then we know that there's this robust, uncoordinated immune response that does occur in individuals, leading to either resolution of the infection or in many cases, progression to much more severe disease. So it's pretty clear early on that COVID-19 was really associated with a very intense multi-system inflammatory response. And this almost feeds on itself like a positive loop where you have the immune response, immune cells migrating to sites of infection and then triggering excess release of cytokines and chemokines, and that's stimulating even more attraction of some of those immune cells and amplifying this, what we've all come to identify as the cytokine storm. And this has really been reflected in some of the ways we've tried to approach therapeutics for COVID-19, looking for agents that are able to tamp down, if you will, the cytokine storm that may be leading to some of these deleterious end organ effects that we've all observed. We do know that some of these conditions tend to be overrepresented in certain hosts, such as people with certain underlying pre-existing comorbidities. We all saw, early on in the pandemic, we all recognized that certain patients were experiencing much more severe disease than others, and this is reflected by conditions such as high BMI, obesity, or being overweight, those who had underlying cardiovascular disease, pulmonary disease, and disease like diabetes. And remember, many of these diseases are already independently associated with pro-inflammatory states. And so you almost see that superimposition between a viral infection that's triggering an inflammatory cascade superimposed on this. And this really reflected and manifested as deleterious effects for our patients. And so one of the end organ issues or systemic issues we wanted to highlight was really this fascinating, built on observations, right? So we saw that there were higher rates of venous thromboembolism, for example, in people who had COVID-19, but this wasn't just even venous clots. We also saw things like arterial clots as well, people having strokes, in some cases, young adults. Which, as we know, can be quite disabling. So I think it's pretty well established that coagulopathy and thrombosis risk is higher in COVID-19 patients, particularly those who are on the more severe spectrum of disease, those with severe and critical COVID, and with estimates ranging in the 50% range for those who have a severe COVID-19. And so we know, we've seen from autopsy studies, for example, that you have this really aggressive, clotting, both in, small and large vessels, which have occurred not just in the lung, but in other organ systems. And that, at least in part, explains some of the multi-organ effects that we've seen in COVID-19. And as you can imagine, there was a lot of work done to try to identify how we address these coagulopathies. And as you can imagine, looking at anticoagulation has really been important. And there's been lots of work on should this be just prophylactic anticoagulation versus therapeutic anticoagulation. It appeared in people who have the much more critical forms of COVID that, in some cases, there could be harms for using anticoagulation. But I think it's pretty well established from studies now that prophylactic anticoagulation should be used in individuals who are in the more severe forms of COVID-19. And so prophylactic low molecular weight heparin has been recommended by the International Society of Thrombosis and Hemostasis, as well as the ASH, but the best effective dose is uncertain. So, a lot of progress has been made. Still lots of debate around what the right dose should be, what form of anticoagulation, oral anticoagulants versus heparin. However, prophylactic anticoagulation, at least, I think there's enough evidence to support that for benefit for our patients. So back to you, David.
Thank you. Perfect. As you can see, we're slowly getting the hang of this nifty new platform. So thank you. Wonderful. So let's move on now to our next objective, which is evaluating patients with COVID-19 to make appropriate treatment recommendations to optimize quality of care and patient outcomes. So we're going to show a video. It's a 3D animation that tries to get us through the different stages of severity of COVID-19. So we'll start the video and I will narrate it. Please keep your questions coming. We will address them. So thank you very much. So I think most of us appreciate this is acquired through the nose and throat. So with mild COVID, you get this southernward movement of the virus into the lungs, where it can start this cascade that Anyema very nicely articulated, where we can start to see not only systemic issues, but local issues with more inflammation, thrombosis in the small vessels, and over time an ARDS-like picture. So I think this is very clearly moving from the top to the bottom, and it's this southernward migration of the virus that I think really defines the difference between a mild case where people get congestion in their nose to full pneumonia and then an ARDS picture. And much of that, what we're going to talk about in our therapeutics and even in some of our preventative strategies is how do we keep the virus as high up as possible? and not let it go south to the lungs where it can cause the cascade of illness that we've been identifying and talking about. So very helpful, and I think that helps us understand this. And another way to look at this is that you'll see commonly when we talk about recommendations for therapeutics and also the clinical trials that are evaluating therapeutic candidates do categorize people based upon framework that generally follows this one characterized here. So mild, moderate, severe, critical illness. And the hallmark of each of these categories basically is how much oxygen, if any, people require due to their illness. So in mild illness, we wouldn't expect there to be any need for oxygen supplementation. These are people who have symptoms, but who don't progress, wherein the pneumonia that is established causes a decrease in oxygenation. With moderate illness, we get more symptoms, of course, and we do see, again, that people can maintain their oxygen level above 94% or so on room air. When we get into more severe and critical illness, we're starting to talk about oxygen support. And initially, of course, more and more with trying to keep oxygen levels normal with non-invasive techniques. But of course, when we get to critical illness, we have to support people's organ function, including respiratory function. So I like this as a nice framework for thinking about this. So there is a difference. Severe and critical are not synonymous in the COVID world. And I think it's helpful to keep that in mind when we talk about many of our therapeutics and some of the clinical research that we've been doing. So Pratish, tell us a little bit about your thoughts about this. And I think we're going to move on, of course, to also talking about risk factors for progressing to severe disease.
So one might ask which risk factors are associated with progression to severe disease. Taking into account the state of evolving data on this subject, we know that individuals over the age of 60, those who are obese, have diabetes, have some form of cardiovascular disease, chronic lung disease, and suffer from chronic health and immunocompromising conditions, including the receipt of a transplant, whether it be a bone marrow transplant, stem cell transplant, or a solid organ transplant, who are pregnant, and also those individuals who have long-standing systemic health and social inequities that they suffer from are groups that are associated with this progression to severe disease. As we move into a discussion about treatment options, let's take a look at another animation that visualizes where treatments may interrupt the SARS-CoV-2 life cycle. Spike proteins S1 and S2 mediate the attachment of the virus to airway epithelium. And the human host cell and engage the angiotensin converting enzyme 2, or ACE2, as the entry receptor. The viral copies are then released from the infected cells through exocytosis. The attachment of the virus to ACE2 is due to cleavage of the SARS-CoV-2 spike protein by cellular proteases, furin at the S1 and S2 site, and the serine protease TMPR SS22 at the S2 site. Inhibition of either of these proteases or simultaneous inhibition of them renders the spike protein fusion inactive. Inside the host cell, the RNA-dependent RNA polymerase is a protein found specifically in the virus and is considered a superior target for the development of safe and effective treatment approaches. Viral RNA-dependent RNA polymerase is a target protein for the active metabolite of remdesivir. It acts as a substrate for the RNA-dependent RNA polymerase, where it competes with ATP for incorporation into the new strands. Molnupiravir also utilizes this pathway to exert its antiviral activity. Many of the COVID-19 therapies we currently use are anticipating using in the near future are available as a result of emergency use authorization. a mechanism to facilitate the availability and use of medical countermeasures, including vaccines, during public health emergencies such as the current pandemic. Consideration for an EUA involves a rigorous review process, including studies evaluating the efficacy, safety, and assuring quality of the products being considered. As a result of issuing an EUA, a healthcare provider fact sheet and a patient or caregiver fact sheet are made available.
Thanks, Pratish. That was very helpful. And I think that animation is really special. I think it helps me visualize more clearly just what the virus is doing when it gets inside of us. The monoclonal antibodies were the first treatments, of course, that received FDA authorization. Can you tell us a little bit about the MABs and which are currently available for treatment right now of COVID-19? Oh, I think we can't hear you if you're on mute. Sorry. Let's see. Okay. Yeah, that's perfect. Thank you. Oh, well, it was for a second.
Oh, can you hear me now?
Yes.
Okay, perfect. So I'm happy to do that. Sorry for the delay. We currently have 3 options for the treatment of high-risk patients who do not require hospitalization or supplemental oxygen for their COVID-19 infection. And it's a little bit of an alphabet soup, but these are bamlanivimab plus etesevimab or casirivimab plus imdemivimab, or sotrovimab. It's important to know that this determination is made by assessment from a healthcare provider, either during an ED visit, an in-person visit, or a telehealth visit. And the NIH guidelines make it clear that there is a recommendation against the use of dexamethasone or other systemic glucocorticoids in the absence of another indication for this population. Again, these are patients who are at high risk for severe disease. And this is distinct from the role of dexamethasone in the inpatient setting for patients who are on oxygen, where we know that there's mortality benefit, not so in this population. So we need to remember that. So moving on a little bit to talk about treatment in children. We do have the same 3 treatment options for monoclonal antibodies in the pediatric setting with some important qualifiers. The first, bamlanivimab plus etesevimab, this EUA is authorized for use in all age groups, so children and adults in all age groups, and so that's important to keep in mind. Separately, the other 2 options, casirivimab plus imdemivimab or sotrovimab, is only indicated for children 12 years and older who are at least 40 kilograms. Again, this is for patients with mild to moderate disease who are at high risk for progression to severe disease. And moving on a little bit, we'll talk also about post-exposure prophylaxis. We're thinking about some of the same agents, but this is for now a different indication. We have 2 of these agents that have EUA available for post-exposure prophylaxis for children and for adults. Of note, the NIH guidelines recommend their use in individuals who are at high risk for disease progression, as we've already discussed, but they have either not been fully vaccinated or are not anticipated to have a robust response to vaccination because of their underlying medical conditions. And then they also have had exposure to someone with SARS-CoV-2 infection. And remember that we define exposure by the CDC's definition of a close contact, so being within 6 feet for a cumulative duration of 15 minutes. So it doesn't have to be all at one time. That can be added up over that 24-hour period. So again, the distinction here is for bamlanivimab and etesevimab, which is available for all age groups for post-exposure prophylaxis, and then casirivimab plus imdemivimab, again for those who are 12 years and up and at least 40 kilograms. So that is for post-exposure prophylaxis. So Dr. Patel did highlight some of these criteria really in identifying those patients who are at high risk for progressing to severe disease when they're infected with COVID-19. And so these are also the same people in whom we really want to get these therapies into. So some of these criteria are listed here. They include older age, being overweight or obese, having diabetes, cardiovascular disease, chronic lung disease, being immunocompromised or having chronic kidney disease, being pregnant, having sickle cell. It's important to note that as a healthcare provider, you really do have some important discretion here. Of course, if someone has multiple risk factors for developing severe disease, you want to really try and make sure those patients get access to these monoclonal antibodies. And then some of the indications are a little bit broad. And in that case, too, you use your discretion as a healthcare provider to really make important decisions and recommendations about access. The other important point on this slide is that we have to keep up to date on the activity of monoclonal antibodies against new variants of concern. Of course, right now, that's Omicron, and we'll have to pay attention to whether or not and how effective each of these monoclonal antibody combinations are against these new circulating variants. And finally, I just want to highlight the situations, the scenarios in which we cannot use monoclonal antibodies. Remember, again, we are thinking about high-risk patients, patients who are at risk for developing severe disease, who are in the outpatient setting. If patients are hospitalized because of COVID-19, we are not thinking about monoclonal antibodies. We have another set of therapeutics for that patient population. However, EUAs do permit the use of these agents in patients who are hospitalized for something other than their COVID-19. So someone is hospitalized for a car accident and they have symptomatic COVID-19 or are at high risk for disease progression, we still want to offer monoclonal antibodies in that setting. Other important exclusions, patients who are requiring oxygen therapy for COVID-19. Again, that puts them in a different risk category and we have different therapeutics for that population. Another tweak on that is that patients who are on chronic oxygen therapy for another reason, but then require an escalation in their baseline oxygen need because of COVID-19. So that's another patient group who would not be eligible for the use of monoclonal antibodies. And I will pass it back to you, Dr. Wall.
Thank you, Dr. Ahunke. So some of the questions that have come in while we've been talking involve monoclonal antibodies. And one thing both you, I think, and certainly Anima and Patish can talk about is timing. So we spoke about treatment with monoclonal antibodies and also prevention. So let's take treatment first. When is it too late to give a monoclonal antibody? Is there a cutoff beyond which we would say chances are that the MAB is not going to work after someone's diagnosed or, let's say, become symptomatic from COVID-19?
So I think for all of these treatments, it's important to recognize that the sooner, the better. So getting people into treatment as soon as, we have confirmed their diagnosis. And within 7 days is the typical cutoff that most guidelines are using and most hospitals are using.
Yeah, it's an important point. I think probably quicker is better, as we showed in the animations. There's a progression even from geography and then, of course, on the cellular level. So I think the sooner we can get antibodies in to people who don't make their own or don't have them already, I think that would be key, or to augment the immunity that people have. The EUAs specify 10 days. I think partly that's because of logistics, especially earlier on with the turnaround time for testing taking as long as 5 days. I think they didn't want to exclude people because of that. But realistically, I agree with you. I think that within 7 days and hopefully within, I would say, 5 days. And Anyema is going to go through some of the clinical trial data, and certainly they included people much sooner than 10 days in their clinical trials. The other thing that's come up, of course, and you mentioned this briefly, is predicting which mAbs will work against Omicron. We know a lot already about Delta, and we know that CASI-MD does work against Delta, and also BAM-EDI, which kind of breathed new life into the drug because we weren't using it very much because it wasn't doing so well about the previous variants. So now we have BAM-EDI, and we do have CASI-MD, but just as that is happening, and certainly most of the virus now is Delta, Omicron comes along. And so, Anyema, any thoughts about which monoclonal antibodies look like so far that they might work against Omicron?
Yeah, so we continue to learn more about that, but I think, we have comments around sotrovimab probably retaining activity against that, but I think CAS-IMI may struggle against the variant. So again, I think it's really important for us to keep paying attention to some of the work done around, seeing how well these antibodies do against variants as they emerge.
Perfect. And Pratish, again, talking about timing, we could also talk about timing of some of our preventative therapies and pre-exposure prophylaxis, if you will, with monoclonal antibody is a very new concept. I mean, this is really just days old. As far as recommending, for people to get a mAb post-exposure, not pre-exposure, but post-exposure, when would you suggest that people think about getting a PEP, monoclonal antibody? Again, in this case, it's CASI-MD following an exposure.
Sure. Again, here, the sooner the better is the case. If in thinking about the mechanism of action in which you're expecting the monoclonal antibody to act, the further the virus goes into the body, the less effective that monoclonal antibody is going to be. So we want to be able to catch the virus at the early stages in the cycle of illness. And so within the first 5 days would be ideal to be able to capture the patient post-exposure to be able to administer the monoclonal antibody.
Awesome. That's perfect. Dr. Abagu, you're going to go through some of the clinical trial data, I think, that underpins some of our recommendations regarding mAbs.
Yeah, great. Yeah, David, happy to talk about the three products that are under EUA for treatment. I conduct clinical trials. It's always great to talk more about clinical trials. And maybe we'll start with the BLAZE trial of BAM-EDI, which I guess blazed the way for other monoclonals, given that it was one of the earliest products evaluated. And so, the BLAZE 3 trial was looking at BAM-EDI versus placebo for COVID-19 in high-risk ambulatory patients with mild to moderate COVID disease. I just wanted to highlight some of the inclusion criteria. These were people age greater than 12 who had at least increased risk for either hospitalization for COVID or severe COVID and had to be in study within 3 days of a positive test. I want to emphasize that I know we had a conversation around duration of symptoms. That wasn't a consideration here. And so we know the demographics of the trial here was that the median age of participants was about 56 years, but at least almost a third were about the age of 65 and elderly. And, decent representation for ethnic racial minorities, 9% African-American, 30% Hispanic Latinx, which is important for those of us who practice in parts of the country that have a skewed demographics towards ethnic racial minorities. 77% of these individuals had mild COVID and mean of 4 days duration. And so, the primary endpoint here was really looking at COVID-19 related hospitalization and any cause mortality by day 29, the composite of those two outcomes. And so the study found that there was a 70% decrease in hospitalizations, 7% risk reduction, relative risk reduction in that primary endpoint. There were also virologic assessments done, and they found there were significant decreases in viral load for those who got the combination therapy, as well as improved and sustained symptom resolution that was also clinically significant. Interestingly, there were no deaths due to any cause in those who received active product. And then the next one we'll look at is the double-blind randomized control trial of casirivimab and imdevimab. These, again, are monoclonal antibody combinations targeting the spike protein. In this case, these are not bind to non-overlapping epitopes as against EDI. So in this study, again, a little bit of differences. Inclusion was age greater than 18, at 18 or greater, and also now in this case, participants had to come in with at least within 7 days of symptom onset. So the demographics here, median age of participants were about 50. Again, 5% African American, 35% individuals identified as Latinx or Hispanic. Again, you see the similar endpoints. Again, COVID-19 related hospitalization or all-cause mortality through day 29. Now, in this case, the median duration of symptoms for participants was 3 days. So the study found that there was about a 71% relative risk reduction, the primary endpoint among those who, for those who received CAS-IMD compared to those in the placebo arm. And this translated to about a 2.2% relative risk reduction. It's amazing how, some of these results are almost superimposable on each other. And then the last study we're going to look at again is, again, a similarly designed trial for those with mild to moderate symptoms who are not hospitalized. So these are outpatient patients. Now, in this case, the study design was a little interesting. So this was, again, 18 years and older. And in this case, you were in the study if you had at least one comorbidity, which conferred on you some risk of, disease progression, hospitalization. But if you're just 55 or older, you were allowed into the study without prejudice to having a comorbidity or not. And for this study, inclusion criteria included coming in within 5 days of symptom onset. And so in this study, median age, again, about 55, again, just paying attention to the oldest within those groups, about 20% were greater than 65 and about 10% were greater than 70%. So this included significant proportions of elderly participants. The ethnic racial representation is as shown. And you can see that a little more than half came in with symptom duration 3 or less. And the comorbidities were quite high. 63% had an elevated BMI that met criteria for obesity. Again, looking at the endpoint of COVID-19 related hospitalization, all-cause mortality through day 29, and this included hospitalizations had to be greater than 24 hours. Again, there was an 85% risk reduction for this endpoint among those who received sotrovimab compared to placebo. And like David had asked previously, preclinical findings suggest that this monoclonal agent should retain activity against the Omicron SARS-CoV-2 variant. So again, it's just great to see similarly designed studies of different monoclonal antibody combinations, either combinations or singly, showing robust protection against hospitalization and death in vulnerable individuals with mild to moderate symptoms. And over to you, David.
Yeah, thank you very much. That's a wonderful overview. I think it was really helpful that you pointed out some of the similarities in the results across these 3 trials of the 3 major monoclonal antibodies. I think the other thing we should point out, of course, and you mentioned this, is that these were studies that were done a while ago, earlier in the pandemic. They were studies that were done before even Delta emerged. So these are results from pre-Delta outcomes. Remarkably, the placebo arms did on par about the same. We're looking at about a 5 to 7% event rate, even though there's some differences across the studies in their definitions of the outcomes, but they were rather similar. And then this huge reduction. So I think keeping in mind that 70, 80% reduction from the event rate that we saw in placebo with the MAB is important when we start thinking about, well, what about, as we're going to move on to newer therapies or things coming down the pike, what kind of results we're seeing from some of the oral agents that are being considered for treating COVID-19 in outpatients. So really, I think, helpful data. Moving on, we will go now to our 3rd learning objective, and this is to identify the best practices to support utilization of currently approved or authorized agents and emerging agents, as we talked about, as we signaled for COVID-19. And some of the questions that have been asked about MABs really fall into this, is how do we use these and what's the best practices? And I think one issue that we will talk about with MABs in just a few minutes is sort of access and how do we do a good job. And we'll open it up for the panel to help share some of their experiences. So I know people have asked questions about that. We do know that getting an infusion is a challenge for many people. So we'll talk about what workarounds could exist and strategies for addressing that. So I'm going to again turn it back over to Pratish to help us understand a little bit more about some of the emerging agents that have been in the news and the media, and I think getting quite a buzz lately for COVID-19 outpatient treatment.
Thank you, Dave. The first agent we'll discuss is oral molnupiravir. This agent was presented to the FDA's Antimicrobial Drug Advisory Committee on November 30th. The majority of the data was from the P002 trial. The FDA received originally an interim assessment of the phase 3 trial, and then in a last minute fashion received additional data with twice as many individuals enrolled as there were in the interim analysis. The trial met the pre-specified interim assessment. Therefore, they stopped any further statistical analysis on the full population assessment. A 48% risk reduction was identified in the interim population from a 14.1% all-cause hospitalization or death rate through day 29 down to 7.3% in the molnupiravir group. When the full population data was analyzed, this risk reduction shrunk to 30%, mainly due to the placebo population experiencing a lower all-cause hospitalization or death rate through day 29. There were a number of safety signals that were identified when that advisory committee discussed molnupiravir. First and foremost was bone and cartilage toxicity. There is an absence of data from pediatric patients regarding long-term toxicity in the growth plates, and juvenile toxicity study results are expected to be forthcoming. The FDA proposed a warning and precaution statement in the fact sheet describing this toxicity. Additionally, embryo-fetal toxicity was also identified as something that required risk mitigation and an assessment of risk versus benefit in pregnant or breastfeeding female. Pregnancy test is recommended by the advisory committee if it achieves the EUA status, and individuals of childbearing age were recommended to use an effective method of contraception for the duration of treatment and for 4 days after the final dose to include a washout period. I'm going to hand it back over to you, David.
Yeah, no, that's very helpful. So really just quick on molnupiravir before we move on, because again, there's some good questions and I think this is interesting. So remind us, Pratish, how many days do people get treated with molnupiravir in these studies?
It was a 5-day treatment course.
Yeah, so it's a BID treatment regimen taken twice a day and then for 5 days duration. And to be completely clear, most of the data that we know about this, almost all of it comes from pretty much press releases and also some of the data that was shared with the FDA. So we don't have a whole lot of information about some of the details. This has not been published yet, even in a preprint, although I expect we will see it soon. So people are asking some questions about some of the details of the trial, but unfortunately, not a lot of that is out yet. But there are some FDA records that I think you can find pretty easily with a few clicks that may help you get some of the detailed data. But I do think that Pratish, your overview, and especially how we went from that interim analysis where we saw, pretty high levels among the placebo arm of, hospitalization, and then it shrunk down. But then when you look at the second half of the study, if you will, the placebo arm started to do better. and there were less events in the placebo arm, which I think we don't see very many studies break it down this way, but I think they did because they saw an early signal and took it as encouraging. But when the full data set came about, we saw a little bit different story. We're going to move further to another new drug that I think is also catching quite a bit of buzz. And I'm going to turn it back to Anyema to talk to us about the Pfizer drug. And this is, I'm not even going to try to pronounce this one. Maybe you guys are much better than I am, but I've already proven that I'm not that good at that. But maybe we could talk a little bit about the Pfizer drug and what we know. And this is like hot off the press.
Yeah, absolutely, David. And again, just the disclaimer again that, a lot of this is also from press releases and not published data, but no less exciting. And I think we all appreciate the role that potentially available oral agents will play in this pandemic. And I think overcomes this concern we have around just some of the logistics we need to be able to deliver monoclonal antibody therapies. This is convenient to patients taking them in their homes. And so one of the other agents that has emerged more recently that's generated quite a bit of buzz is the boosted protease inhibitor by Pfizer. So this is now called nirmatrelvir, which again, want to be clear, is would be co-administered to ritonavir. For those of you in the HIV world, you know that we use ritonavir to boost the levels of protease inhibitors so that way you can alter the pharmacokinetics favorably to allow less frequent dosing. And so we'll discuss the interim results and then the final results that have been available to us. And so this was the interim. The first slide is on the interim data on the phase 2/3 study evaluating this combination, double-blind study, randomized, evaluating the therapeutic intervention versus placebo. And entrants into this study had to be 18 years or older, and as shown, had to have at least present within 5 days of a laboratory confirmed diagnosis of SARS-CoV-2 infection. So again, as you can imagine, this is trying to target people earlier on in their disease course. And in this case, again, these are people who have mild to moderate symptoms and are required to have at least one characteristic or underlying medical condition that was associated with an increased risk of developing severe disease. And we'll just mention that they have two cohorts. They have a high-risk cohort, which this describes, as well as a standard risk cohort that did not necessarily have to have a high risk for hospitalization. And so the endpoint here was looking at COVID-19 related hospitalizations or death from any cause through day 28. So, similar primary endpoint to the monoclonal antibodies. And, amazingly, nirmatrelvir, ritonavir combination showed an 89% risk reduction. And the data suggests that safety was favorable, with adverse events being comparable to those who got placebo or the combination therapy. Now, this drug was delivered, I think, as a twice daily medication and given also for a 5-day period, similar to molnupiravir. And so this is the final results of the study as well that have been reported. Again, I think the study has been recommended to be stopped due to overwhelming efficacy in those who have received intervention arm. And I think if I remember correctly, this wasn't fully enrolled, but enough numbers to show this important endpoint. And so again, people enrolled in this group were those who have high risk for progression. And you can see if you're not vaccinated or you had one underlying risk factor, including age greater than 65. Again, treatment was initiated within 5 days of symptom onset. It had to be laboratory confirmed. And interestingly, the results again in this cohort showed that again, the composite outcome of COVID-19 related hospitalization of the all-cause mortality, 89% risk reduction in those who received the boosted PI compared to those who received placebo. And interestingly, when you look at the subgroup of those who actually experienced mortality, there were no deaths reported in people who got the protease inhibitor at the time of study reporting. Again, for the standard risk, the standard risk patients also were lower risk for progression, as shown there, and the adverse events was kind of similar between both groups. So again, this is just really super exciting data on the protease inhibitor, and this data has been fed to the FDA as a rolling submission, and we'll see how that evolves before year end. Over to you, David.
Yeah, no, thank you. That was excellent. So again, two interesting, I think, oral agents. We'll see what happens with molnupiravir, as we've talked about. Definitely some concerns. We saw some efficacy results that look. It's hard to compare across studies, but it's hard not to. And so, especially when we saw the MAB studies align so nicely in their outcomes. And here we have two oral agents, both given for 5 days. Some similarly designed studies, although maybe different geographies. But again, some differences across the outcomes, but also the concerns with molnupiravir and some of the mutagenesis data that again is giving some people pause and concern. We don't know just yet. I know people are really interested in understanding when maybe the protease inhibitor will be authorized. I don't think we know that yet, but I think there's a lot of urgency. The other thing we should mention always is that both drugs would be expected to work against Omicron. That the mechanism of action shouldn't be such that mutations in the spike protein would lead to any decrease in the activity of molnupiravir or the Pfizer drug. So very important, but I think we will be hearing more about this from the FDA within the very short coming weeks. And again, look out for that, because what an additional thing that we find is the data submitted to the FDA is much more detailed, of course, than the press releases. And you can find out a lot about these drugs in those FDA presentations, which become available for public consumption right before the meeting. So that's wonderful. Great. So we're going to continue, and there's going to be plenty of opportunities to answer the pending questions, and we're going to have more discussion. So what will treatment look like? We do have the therapies that we've talked about now and the ones that may be on the cusp. So we'll spend the next section just talking more about this and having more discussion and not so much presenting any data per se. But we'll move next to survey questions. And so hopefully this will pop up for you on this platform. But we'd like to see where our audience is related to how you're tackling COVID-19. So the question is, in what percentage of patients with mild to moderate COVID-19 in your practice have you treated with monoclonal antibodies, with any monoclonal antibody? And the choices are A, none, B, 1% to 25%, C, 26% to 50%, D, 51 to 75%, and E, 76 to 100%. Please vote now. We will show the results. All right, very helpful. So almost 60% have said that they have not treated their patients with mild to moderate COVID-19 with a monoclonal. And then we have about a third who've treated some. And then, yeah, maybe about a third to 40% have treated some at some point. Some of you are big, 50 to 75%, 4% of you. Okay, great. Let's move on to our next question. And this might be really appropriate given those results. So what barriers have you encountered in initiating treatment for COVID-19? And A, you prefer to watch and wait rather than treat. B, the EUAs are happening before I've had a chance to digest the data. C, lack of experience using the MABs. D, patient reluctance. Or E, access to an infusion center where the MAB can be administered. So again, please vote, and we'll see what you all say. All right, so a lot of folks who don't have as much experience, access to an infusion center for sure. Those seem to be, and then some patient reluctance. Okay, this is really helpful. Okay, thank you. All right, So that is a wonderful segue to some of the issues that we wanted to talk about in discussing more about monoclonal antibodies specifically, because those are what we have right this very moment, although that can change any second. But really operationalizing this and thinking about what outpatient therapy will look like. As you all have indicated, and as we've talked about a little bit, there are challenges to accessing monoclonal antibodies. And that's something that I think we have to talk a little bit more about. The other thing, of course, is even when we do have oral therapy, there's going to be caveats. We didn't talk about some of the issues with the Pfizer drug, but it does have ritonavir. Ritonavir is an inhibitor of the cytochrome P450 system. And for some people on some medicines, maybe 5 days of ritonavir won't be a problem. For some, it might. And so that's going to be a limiting factor. And if we had to carry around the list of drugs that could be impacted by ritonavir, it would be very long and probably not fit into our pockets. And then there's the logistics. And so we can talk a little bit about this. And this gets at some of the questions that have come through the portal asking us about operationalizing monoclonal antibodies. So I think we should have a discussion amongst our panelists about this and maybe, really bring up some of the issues that we've all experienced and maybe share some of the things that folks have done to make monoclonals more available to people. So we have 3 centers represented here, right? We have Yale in Connecticut, we have Vanderbilt in Tennessee, and here in North Carolina. And I think we can get different perspectives on what barriers you all have seen to monoclonal antibody use in the populations you serve. So I'm going to start with you. Tell us a little bit about what you're experiencing and some of the things you're thinking about as far as MAB access.
Yeah, I think, I'll let Dr. Patel talk about some of the operationalization of our infusion programs. I think all of us are fortunate to be in academic centers where we do have fairly robust infusion programs, but not without challenges. One of the things that's really important to me to speak to, though, is thinking about disparities on the provider systems. There are a lot of ways to think about constraints in logistics of administering the program. But one thing that's important is that, of course, we know that there are a lot of racial and ethnic disparities along the entire cascade of testing, treatment, and outcomes for COVID-19. And if we don't offer treatment to high-risk patients, those disparities just simply worsen. And unfortunately, we are seeing this at a system level, whether we're talking about monoclonal antibodies or inpatient treatment. So I want to make sure that we recognize when we're thinking about high-risk populations, the structural barriers that may be in place for racial and ethnic minority populations, and making sure that we don't worsen those disparities when we are designing our systems for delivering monoclonal antibodies. But like I said, I think Dr. Patel has a little more direct experience in our system. I'll let him shed a little bit of light on how things have been done at Vanderbilt.
Thank you, Dr. Honkai. As a large academic medical center, we're definitely positioned to respond to a pandemic like this, but also being a large entity has its own challenges. We were fortunate to have considerable support from hospital administration, so we could be as nimble as possible to move staff from pharmacy, from infectious diseases, from nursing, and have truly a collaborative approach to respond to a fairly changing view of what's going on with COVID and how we respond to it. So for the monoclonal specifically, we had to make sure with those patients that were receiving monoclonals for post-exposure prophylaxis, we were not commingling that population in our oncology infusion center with those patients that were at high risk for developing COVID. So we set up separate area for monoclonal infusions. So we had to get support for a specific area to infuse, specific staff to infuse those, and also informatics support to build the ordering panels and such to make sure that we were providing these infusions to the appropriate patients. And we were putting forth the fact sheets that were necessary to be distributed to the patients before they received the monoclonals as part of the process to get consent. And also then to be able to report back to the state and to the Department of Health and Human Services information that was necessary to continue to take part in the allocation process, to continue to receive more of this medication for patients that needed it.
Yeah, and I think you guys have done a really good job. I think being in a rural southern state like you, we definitely have faced challenges. And I think you both have pointed out some of the logistical challenges. I think one, so there's the sort of physical operational stuff. Like, how do you get infusion centers? How do you make sure that infusion centers are around where people are? Not everyone can drive, to Vanderbilt or to UNC. Maybe in New Haven, people can take a bus to get to Yale to get their infusion. But I suspect you guys have thought about other places to infuse people too. Here, we really have had to decentralize access to MABs. So that's important. But it's also the other thing, people don't know about it. And if people don't know about it, including their providers, they're not going to access it. You can build all the centers you want. So I think that there's a lot of education. And that's why I'm glad so many people have registered today to be part of this. So you can learn that there is, someone said it in the questions, is it a cure? It is a cure. If it's able to be administered and knock COVID out of someone's body, to attach to SARS-CoV-2 and not allow it to perpetuate in your system, that to me sounds like a cure. So people have to recognize that there are these cures, that there are these treatments that can prevent them, as we've shown, reducing the risk of getting hospitalized, which is really the goal, right? If no one was hospitalized with SARS-CoV-2, it would be like other human coronaviruses. Like, we wouldn't care. Like, we wouldn't be masking, and we wouldn't have these mandates and all these things that we're doing to keep each other safe if people didn't end up getting in the hospital. So I think it's really key to recognize that these are very important, and we have to spread the word in our churches, our synagogues, our mosques, our community centers. Providers have to know about this so that when someone calls and says, I was diagnosed with COVID-19, is there anything I can do? The answer isn't Tylenol, right, and fluids. So I think it's really key to make these on-ramps. And Yamin, you work in a little bit different circumstance. Tell us what you're doing in New Haven, in that area, to get people access to MABs.
Yeah, that's just a great point. And I think, like Ima has rightly said, I think that recognizing, first of all, and even just the data on, because I think, I've done a talk like this where we've asked people just what's the data on the ethnic, racial, distribution of patients who've administered MABs, and we don't even have that data, right, on how that's done, although we do recognize that because of some of those barriers that we've cited, that, people who are most likely to suffer negative consequences from COVID don't always have access to these highly effective therapies that can prevent them from being hospitalized and dying. And so I really want to double down on what you said, David. I think that the refusal rates for monoclonals, I think I've seen surveys on some of the greatest reported barriers to monoclonal antibody use. And one of them that pops up at a high frequency is that people don't have confidence in those therapies or have misconceptions around those. So we can't overemphasize, provider educating patients, especially because you have that narrow window, regarding time of duration of symptoms to get these effective therapies in. And I think we need to do so much better with messaging, including to potential patients around the benefits and safety of these products. Now, one ways we've tried to address some of those issues. So one is cost, right? So we know that the government has, for CAS, India, and BAM-EDI, if I'm not wrong, has acquired many doses of those, so there's no really cost to the individual for those drugs. But there's the cost of administering those drugs. And so what my institution has done for people who do not have insurance is we actually absorb the cost give the drugs to those who do not have the ability to pay. And I think that that's been very helpful. Another issue was even just transportation for people to access sites where we've expanded sites to include satellite sites, urgent care centers that we have affiliation with, so just to make sure that there's much more accessible locations where people can go for infusions. And, we've actually had to make transportation arrangements for people to be able to make it to some of those infusion centers for them to receive treatment. So I think these are some of the things. And one last thing I'll just mention also is also working with community providers and testing sites, because again, that's really the portal of entry, or where people get identified as having COVID-19, and trying to then create that linkage to care, if you will, between where people get tested and informed of their results and where services can be administered. So frankly, monoclonal antibodies in many cases are easier said than done. And we've all had to really work out the logistics to make sure there's much more equitable access to these really important treatments for patients.
Yeah, that's great. It's really important. So I think folks should recognize that we didn't talk about toxicity, safety data in the studies because there's basically none. Not no data, there's basically no toxicity. I mean, sometimes people get an infusion reaction. Anytime you infuse or inject a protein, you can get some sort of reaction. They're very mild usually, and they resolve quickly, sometimes with an antihistamine, and they're pretty rare. We've given 12,000 people MABs in our system since they became available Thanksgiving in 2020. So we have a lot of experience with this and all over the state. And I think we've done a good job of educating people, having easy on-ramps, like a phone number you can call to self-refer yourself and then get a video visit, printing flyers in English and in Spanish and handing them out at testing centers. I just delivered a whole bunch of those today to a testing site. So we really just have to get the word out. But it's pretty hard to think of somebody who meets eligibility vis-a-vis being at risk for severe COVID, for whom the monoclonal is contraindicated. I mean, you really would have to think hard. Pregnant women can get it. In fact, probably the antibodies that are in late trimester, the antibodies that remain will probably protect the baby. So I think that there's a lot of people who are worried about, newer therapies, about something like a monoclonal. But I will say, in my experience, people who start to get symptomatic, their hesitancy for getting some of these newer interventions that were developed during COVID-19 starts to diminish once they start sucking air to get more oxygen into their system. So I think it's being reassuring. Yeah. The cost, I think, again, yeah, I'm sorry, go ahead, Anna. Go ahead.
No, I just wanted to kind of tag on to that point, because I'm sure many of us saw during the Delta wave, and fortunately here in Tennessee, we have about 50% vaccination, complete vaccination. And of course, the infusion centers, the ones with our hospital and the community ones were full of people who weren't vaccinated and wanted monoclonal antibodies. So I think, that becomes a really challenging situation in and of itself. But I think that, being aware as providers, that these exist, that they're safe, that they are highly effective, is one step in this cascade of many things that we need to do to try and make these treatments more available to our patients.
Absolutely. Questions have come in about administration. So we keep talking about infusions. I do think we should mention that CASI-MD can be given subcutaneously in the abdomen. We did this. We had a jail outbreak a couple of weeks ago. So getting infusions in the jail was going to be challenging. So we went in and we were able to give it to people in shots in the belly. So it's subcutaneous, much like insulin. Does it work as well as IV? I don't think a higher risk person, maybe like a transplant patient or someone who had who's on chemotherapy, I would give sub-Q if I could help it. But I think for most of the people who are not at the highest risk, I think sub-Q, especially, I'd rather give someone sub-Q than have them not get it at all or have to wait 3 or 4 days to get it. So sub-Q for CASI-MD. We know about that. We don't have any IM treatment right now. We have an IM product that can be used for pre-exposure prophylaxis that again is just days old. And that could be for people who can't get vaccinated or have had a bad reaction to the first vaccine, or who are expected not to mount a response to the vaccine. And that could be administered every 6 months. That product made by AstraZeneca, it's 2 antibodies, some mixed data about whether or not this is going to be effective at preventing or treating Omicron. So jury's a little bit out, some mixed data, but it doesn't look robust. So we'll have to see more about that. So that's a really good question. There was a question about, can you give monoclonal antibodies to people who are vaccinated? So Pratish, do you want to handle this one? Because I think it's good to be very clear about vaccination and monoclonal antibodies.
Definitely, Dave. Thank you. So vaccination imparts a level of protection to immune competent hosts. When you have patients who are immunocompromised, you have to set them in a different bucket. In somebody who has an intact immune system, a vaccinated individual should be able to make antibodies to the vaccine after they've completed the full vaccination series, and now the vaccination series plus the booster. So monoclonal antibodies in a vaccinated individual doesn't impart the same level of protection that it would in an unvaccinated individual.
And then certainly no problem if somebody, this comes up, somebody says, well, I was, and this is happening now, and we may see it more with Omicron. So people say, well, I was fully vaccinated. I got my 2 shots. My last shot was in April. I haven't been boosted, let's say. Can I get a monoclonal antibody now that I've gotten COVID-19? I've been diagnosed right now. I'm symptomatic. I meet the EUA. And the answer is yes. I mean, right now, the reason being, maybe you had antibodies and they waned over time. We're seeing an increase in hospitalization, not a lot, but some of people who've been vaccinated. But these are people who were vaccinated 6, 7, 8, 9 months ago. So there may be some decrease. This is again where boosting is really important. And we could spend a long time talking about, all of us, why everyone should get boosted. Because we do know that antibody levels and maybe other immunity wanes. And because with Omicron, the current vaccines look like they work really well if you're boosted. If you're not boosted, they may not work as well. So it's not a contraindication because these people just may not have antibodies, and you're going to top them up by giving them the monoclonals and preventing them from getting more ill. There is this issue, of course, with if you have monoclonal antibody infused or injected and it's circulating in your system, should you then get the booster a week later, or 3 weeks later, or 4 weeks later? Early on, we told people to wait, just because, for one reason, natural infection probably protects you for some period of time. 2, there was a theoretical concern that the monoclonal antibody might attach to the spike, because that's what it's supposed to do, that you make when you get vaccinated. That's very theoretical. I don't think that there's really too much that I would be concerned about. So I think if someone wants to get vaccinated, a month or 2 months after they've got COVID-19 and got a MAB, I don't have a big problem with that. I think it's probably fine. I don't know if others feel any differently. Great. And here's what we were talking about for the pre-exposure prophylaxis. None of us are going to try to pronounce these 2 names of these medications. We'll just go with brand names, unfortunately, and have to, now that we're in a world of Moderna and Pfizer and J&J. So this is the AstraZeneca IM. And so we'll have to see how this plays out and just see where things are headed. But it does look like that this could be something for some people. And this might be really important, we should mention, for those people who got vaccinated and, they're transplant recipients, or they're on rituximab or B-cell inhibiting drugs. And no matter what you do, they're not mounting a response. And they've been shut in, they've been avoiding people. So maybe getting a monoclonal that could protect them from infection might be really important. So I think this is something that we have to keep an eye on. And again, there's studies that have looked at this and shows a reduction in development of symptomatic disease in people who are able to get this. So I think this is really important to keep, and I think there'll be others. Sotrovimab may also be something that we'll see in the future that could be used. So we are going to do a little bit more crystal balling, and that doesn't mean we won't get to some of the questions about stuff we've talked about before. But I do think it'd be interesting to ask our panelists, what you think is around the corner and what you think is going to happen with therapeutics moving forward. And I know that that's a lot and it's hard, but maybe, Naima, I'll start with you. I mean, you think about this a lot. What do you think is going to happen over the next, let's just say, few weeks to few months as far as outpatient therapeutics?
Yeah, so I think that it's been just great to see the evolution of therapies. We've talked about how the monoclonals have been quite effective and utilized and based on solid data. And I think we clearly see an evolution towards maybe effective oral therapies, which I think will really take away some of the concerns around logistics and much more user-friendly option, if you will, for those who get COVID-19 and can be treated. Just a physician calls in a script. I think the next curveballs would be, what happens with, variants emerging and spreading and what we do with that, especially in the context of, suboptimal vaccination rates, which I think promotes, the spread, of those variants. And I think that, moving forward, I think that, we need to keep adapting our therapies to threats as they emerge, and testing products to make sure that we keep offering people what can give them probably the most benefit at that point in time. I strongly feel that there's really no substitute for vaccines. I know the monoclonals have been shown promise for PrEP for certain groups, and it looks like if you get COVID, some of these treatments do great with protecting against hospitalization and death. But I think we probably should do more to make sure that we vaccinate, a lot more people. I think that puts us better on the prevention end of the spectrum than having people need treatment. Remember that a subset of people do have long COVID, so that even if you get infected and you don't get hospitalized or die, there's always a risk that you could have, long-term consequences of COVID-19. So again, that's what things like vaccines avoid that therapeutics cannot prevent.
Yeah, great. Naima, what do you see around the horizon? And maybe how much do you think oral therapy, like the protease inhibitor, how much do you think that's going to be a quote unquote game changer?
Yeah, I mean, I think, first of all, just reflecting on where we are now relative to where we were with the novel coronavirus, and we have options for early treatment for high-risk patients. We have treatment for patients with more severe disease, pre-exposure, now post-exposure prophylaxis, vaccines clearly at the mainstay of all of that. So the tools in our armamentarium are growing. I think that it's really interesting to think about what's going to happen with Omicron, which may be a less virulent, which may not, predispose to more severe disease. And that could mean that there are a lot of patients who are going to be eligible for this monoclonal type category, high-risk people with less severe illness. And so I think oral agents would definitely be a game changer in that setting, especially if there are more patients who are eligible. So I think that we really need to pay close attention to the EUAs that may come down the pike. And as we're doing now, educate ourselves, educate our patients on what the options are. And if these can tear down some of the logistical barriers that we've described, we really need to make sure we're paying attention to them. Of course, we want to balance caring for our patients and protecting the healthcare system, the strain on the healthcare system as well, which is what, these monoclonals really help us to be able to do to keep people out of the hospital. So I think we need to really pay close attention to those oral agents.
And Pratish, your quick crystal ball.
I think I could echo a lot of the things that Dr. Obuagu and Dr. Honkai have mentioned. I think the oral therapies are definitely going to be here to stay, especially because from what we have seen thus far, the variation in the genetic changes between the different variants have not necessarily targeted where our oral therapies are targeting the virus and its life cycle. So I think they are going to be just one notch in our armamentarium. We'll just have to use them as part of the vaccination, the monoclonal antibody, and the oral treatment as a whole, and just have to consider where the patient is in the course of treatment, what their risk factors are, and what data that we have to date in regards to that treatment.
Yeah, no, that makes a lot of sense. And I do think stratifying to understand who, I think we could do this talk again in 6 months, trying to figure out and focus on who's the right candidate for which therapy. Because right now we've seen robust data for the monoclonal antibodies in people at risk. And while the protease inhibitor looks good, we'll have to see more data from that. Certainly molnupiravir would not be something I'd be thinking about giving to a higher risk person, given the data we've seen, but a lower risk person, I could see it being a lot like oseltamivir, that we give to people to try to make them feel better, maybe reduce risk, but not a home run, but maybe help out. So lower risk people rather than higher risk people. But, maybe the protease inhibitor will be on par with the monoclonals, and that would help us have an oral therapy much easier to get. Supplies of those medications, of all the medications, are severely limited right now. The use of monoclonal antibodies going up. There's not enough sotrovimab to treat everyone who needs it with Omicron. And we don't know enough how much of the Pfizer drug will be around, but suspect it's not enough for what we're talking about. So we'll have to see not only about who's right, but also the supplies. So I'm going to move to the SMART goals, and then we'll take some more questions. I mean, again, Emma and Nima and Pratish, you've done a great job of going over a lot of data. Any one section of this, any of the one learning objectives, really could have taken well over an hour and a half to go through. So I think we've covered a lot. I know that there's a lot of information, but hopefully this will also spark people to, do a deeper dive based upon what we're talking about and find good information from CME outfitters and others. So let's go over some of what we've talked about. So I think for looking at some of our SMART goals, we certainly want to be able to define severity of COVID-19 illness to determine the management course. Again, this is kind of lining up where people are, and it's just what we were talking about right now, where people are in the severity of their illness to understand what therapeutic or intervention makes the best sense. We see this a lot also in hospitalized patients. Identify patients for risk of progression to severe disease and poor outcomes. This is a moving target, and it's really important because we don't always know if you're fully vaccinated. Are you really fully vaccinated? We haven't checked your antibody levels. Just because you got the shot doesn't mean it. So we have to understand more about this, and I think we'll learn more about this, but certainly we have some data right now that help us understand who's more likely. Right now, of course, the priority should be for people who are unvaccinated. Those people can do very poorly very quickly. They make up 85 to 95% of our inpatients, and certainly those who we expect may not mount a good response to vaccine or still have a response to their vaccine. Initiate treatment early in the course of COVID-19. I think this makes a lot of sense, as we've talked about from a pathophysiologic standpoint. Take a cautious approach to the data and really be careful. Again, press releases are not peer reviewed. They're not explicit. They don't have a lot of detail. Preprints maybe move us up a level, but again, I think we really do want to trust as much as we can good sources of information and help beat back any misinformation. And then reassess treatment choices as the pandemic evolves and variants change. This is key and gets to what we've just been talking about for the last 15 minutes. The situation is changing. No one knew what Omicron. No one knew that Omicron was a Greek letter, a month ago. Now we know it, and now we're already trying to figure out, well, what comes next after this one? What letter is next in the sequence? So things come from left field. This is very unpredictable, very dynamic. We're getting lots of data every moment. Some of it conflicting. It confuses people. This is science on steroids. So we just have to be really careful and thoughtful about what we're looking at. Be critical, but don't be dismissive. There's a lot of good data out there. People are doing a great job. And I think we're really seeing, especially when things line up and you're seeing consistency from different labs or different places. And especially if it comes from Yale or Vanderbilt, you can totally trust it. So I also want to remind people that the animations that people are commenting on, they are available. Okay, so they will be on the website. So that will be available for you to use, share, and talk to people about. And I want to make sure that everyone knows to ask their questions, make sure that you can do that so that everyone knows to do that. And let's see if there's any other questions that came in that I thought would be helpful for us to talk about. One question that came up that I thought was pretty interesting was in people, so this is interesting because it comes up in our clinic as well, people who, they're not the highest risk. Maybe they're 30 and their BMI is 26 and they don't have other risk factors. Do you give them a MAB? Do you not? They qualify on the EUA because their BMI is, above 25, as is something like 80% of Americans. But are you guys currently doing any sort of, for lack of a better word, rationing of your monoclonals right now?
Yeah, David, I think it's if you have a shortage, I think that's when you start to talk about triaging. And I think that's why you alluded to vaccination status, et cetera. So, early on in my institution, when we had an initial shortage, we did have much narrower criteria than FDA EUA. So I think really obesity, elderly, and having a serious comorbidity. But I think as shortages have eased, although I know there's still a looming concern because I know a certain number of states were accounting for the vast majority of requests for monoclonal antibodies. So I think if it's really just driven by, supply. And I hope, otherwise that individual should receive a monoclonal if it's available.
How about in Vanderbilt? Are you guys triaging or stratifying, or are you taking all comers who meet the EUA?
I think we've definitely had a similar approach. Sorry, go ahead, Dr. Patel.
Sorry. We took a similar approach as Dr. Ogbuagu mentioned early on when we had limited supplies of monoclonals. We did have tighter criteria for acceptance of the EUA criteria, and then creating a specific subset of criteria for our patients. Right at this point, the supply is essentially matching the demand. So we have not exercised any further restriction of the EUA criteria for the monoclonals.
Great. Okay. I'm going to move us along because we only have a few minutes left. You've done that. That's great. So I think we're going to go to the after the show. And let's see what happens next. Websites here. This is the hub, so people can get information about that. And then, of course, to receive credit for this activity, you must complete the post-test and also do the evaluation online. And again, you'll be able to get CME credit, and you'll be able to get your certificate immediately upon completion. And again, I want to thank, again, our panelists, this, and also to CME Outfitters, who spent a lot of time developing the animations, developing the content, a lot of great information. You can go back to it, review it, go to the sources. You might have heard it here first, but this is not going to be the last that you hear about everything we talked about today. This is moving very, very quickly. But really, I think that the one key message, I think, from the questions and from what you heard today, monoclonal antibodies are really important. And we know there's bottlenecks to using them. Try to overcome them. We know that a lot of people who could benefit from them haven't heard about them or don't have access to them. So please understand that. Right now, that's the only thing we have to really treat people outpatient with COVID-19. And if you do have to stratify by risk, we are starting to do that because our demand is exceeding our supply. Then do so, but really try to get your transplant patient, your immunocompromised patients, your people who are on high doses of corticosteroids or Tux. Those are the people you want to make sure you take care of. So let your clinicians know about it, spread the word, make sure people all over hear about it, not just the academic medical centers, and continue to do all the hard work that you all are doing to help get more people boosted, more vaccinated, and access to treatment as they needed to keep them out of the hospital and get us back to normal. So we're going to close out tonight. Thank you again to my friends. You did a great job, and to everyone out there for sticking with us to the last minute.
Thank you.